Physical examination of the chest is a vital part of respiratory assessment. Using the 4 steps of inspection, palpation, percussion, and auscultation, nurses can recognize changes in the patient's respiratory status and intervene before serious problems arise. Imaginary lines can be drawn on the chest to aid in identifying underlying organs and any abnormalities. These are the mid-sternal line, the left and right midclavicular lines, the mid-spinal line, the left and right mid-scapular lines, and the mid-axillary lines. Next, identify the suprasternal notch, the depression just above the manubrium or upper segment of the sternum. To locate the manubriosternal junction, slide your finger down the manubrium until you palpate a bony ridge. This landmark corresponds to the level of the second rib. It is also referred to as the angle of Louis or sternal angle and corresponds to the level of the carina. Slide your finger laterally to feel the second rib. From there, you can palpate downward and locate the second interspace, third rib, third interspace, fourth rib, fourth interspace, fifth rib, and fifth interspace, and so on down the chest. The apex, or upper border of each lung, extends 2 to 4 centimeters above the clavicle, and the lower border of each lung runs from the 6th rib at the midclavicular line to the 8th rib on the lateral chest wall. Included within this area are the right upper lobe, the right middle lobe, the right lower lobe, the left upper lobe, and the left lower lobe. The term lingula is often used when referring to the segment of the left lung which corresponds to the right middle lobe. The vertebral prominence is the spinous process of the 7th cervical vertebra. Flex the neck forward and palpate the most prominent spinal vertebra. If 2 vertebrae feel equally prominent, they are usually C7 and T1. The lung apices extend to the level of T1. The lower border of the lungs is usually at the level of the 10th rib. With deep inspiration, the lungs may extend to the level of the 12th rib. Only the upper lobe and lower lobe are available for examination posteriorly. Also, the lower lobes extend upward to T4 and occupy most of the posterior thorax. Begin with inspection. The room should be well lighted. The patient should be unclothed to the waist and positioned in a semi-Fowler's or seated position. Reassure the patient that the length of time you spend closely observing the chest does not mean that any abnormality exists, and that you will explain your findings upon completion of the examination. Inspect the skin for swelling, nodules, lesions, bruises, or scars from surgery or trauma. Inspect the skin for redness or pallor. Inspect the lips, buccal mucosa, and nail beds for cyanosis. In darker-skinned individuals, cyanosis is best detected by inspecting the buccal mucosa and nail beds. Causes include inadequate oxygenation, decreased cardiac output, vasoconstriction, and vascular obstruction. Inspect the fingers and nails for tobacco stains. Clubbing is most commonly seen in patients with lung cancer, cystic fibrosis, congenital heart disease with a right-to-left shunt, and subacute bacterial endocarditis. In early clubbing, the normal nail angle of 160 degrees is increased to 180 degrees or more. The skin at the base of the nail bed may feel spongy. In advanced clubbing, the fingertips become enlarged and the overlying skin is smooth, stretched, and shiny. The nail may thicken, harden, and curve on the distal end. Note the shape and symmetry of the chest. Observe the slope of the ribs. Normally, the ribs have a 45-degree slope in relation to the spine, and the ratio of the anteroposterior, or AP, diameter to the transverse diameter is 1 to 2. The AP diameter normally increases with age. In diseases such as asthma or emphysema, The ribs may assume a more horizontal or 90-degree angle. This increases the AP diameter to a ratio of 1:1, a condition known as barrel chest. Inspect the sternum for any musculoskeletal abnormalities which may inhibit normal rib cage excursion and lung expansion. Pectus carinatum, or pigeon breast, is the result of childhood respiratory disease and is characterized by a convex or prominent sternum. Pectus excavatum, or funnel chest, is the result of a congenital abnormality and is characterized by a concave or depressed sternum. Observe the chest wall during respiration. Move to a position directly in front of the patient. If the chest is viewed from an angle, movement may appear to be asymmetrical when no abnormality is present. The normal respiratory rate is 10 to 20 breaths per minute. Expiration is twice as long as inspiration, giving a normal inspiration to expiration ratio of 1:2. Observe for symmetrical bilateral expansion and abnormality in rate and rhythm. Bradypnea is a rate less than 10 breaths per minute. Tachypnea, a rate greater than 20 breaths per minute. Kussmaul breathing, a constant pattern of rapid and deep respiration seen in metabolic acidosis. And Cheyne-Stokes breathing, a progressive increase and decrease in tidal volume, followed by a period of apnea and a repeat of this pattern. Apneic periods are usually the same length and should be timed. The terms hypoventilation and hyperventilation should not be used to describe a breathing pattern. Hypoventilation denotes a higher than normal arterial CO2 level, and hyperventilation a lower than normal arterial CO2 level. Look for signs of respiratory distress. Note the use of accessory muscles. Note retractions of the intercostal spaces, nasal flaring, exhaling through pursed lips, or splinting during inspiration. Note use of positioning to assist breathing, such as the tripod position assumed here. For posterior chest inspection, have the patient lean forward with arms placed to move the scapulae apart. Alternately, the patient may be on the side or in bed. Observe for any abnormal curvature of the spine. Kyphosis is an exaggeration of normal convexity of the spine, scoliosis an abnormal lateral deviation, and kyphoscoliosis a combination of the previous two abnormalities. The second step in chest examination is palpation. Assess the position of the trachea. Place the second and third fingers into the spaces on either side of the trachea. Ask the patient to bend the head forward. Slide the two fingers down the sides of the trachea. If the trachea is midline, the spaces should be equal on both sides. If the trachea is not midline, the spaces will be unequal and your fingers will move laterally as simulated. Disease processes which may alter tracheal position include a large pleural effusion, tension pneumothorax, mediastinal mass, or postpneumonectomy. Assess the degree and equality of thoracic expansion. Measure diaphragmatic movement by placing your hands at the lower edges of the rib cage. Slide your hands toward midline until your thumbs touch. Note thumb diversion after maximum expiration and maximum inspiration. Thumbs should separate evenly about 6 to 8 centimeters. Posteriorly, place your hands with the thumbs meeting at about the 8th thoracic vertebra. The thumbs should separate evenly, about 3 to 5 centimeters. Diminished movement may occur with a barrel chest, as seen in this patient, or be caused by splinting from postoperative pain. Unequal or absent movement may occur over a pleural effusion, atelectasis, or with a pneumothorax. Fremitus is caused by vibration of the vocal cords on phonation. When this vibration is transmitted from the bronchopulmonary system and felt on the chest wall, it is called tactile fremitus. The term rhonchal fremitus is used to describe palpable vibrations produced by thick secretions. The palm of the hand or a closed fist may be used. Ask the patient to repeat 99 each time you reposition your hand downward. If both hands are used, place them in similar positions on each side of the chest so that comparisons can be made between the vibrations produced. Alternately, one hand can be used and moved side to side. The intensity of the vibration will vary between individuals depending on pitch and intensity of the voice and presence of adipose tissue. Normally, vibration should be most pronounced in the upper chest over the areas of the trachea and mainstem bronchi. While palpating for fremitus, note any tenderness, bulges, or crepitation. Crepitation is a palpable cracking sensation that occurs when subcutaneous tissue contains fine beads of air. Fremitus will increase in conditions where there is more solid or liquid medium in the lungs. Examples include pneumonia, atelectasis, or a lung tumor. Fremitus will also increase in lung tissue just above a pleural effusion because the lung is pushed upward and is more dense. Fremitus will decrease when there is air or fluid in the pleural space because transmission of vibration is impaired. Examples include the areas which overlie a pleural effusion or a pneumothorax. Fremitus decreases when the density of lung tissue is reduced, as in barrel chest and lung hyperinflation. Fremitus will be absent if a lung tumor or atelectasis obstructs the bronchi, preventing transmission of vibration. When palpating the posterior chest, avoid the patient's scapular areas, since bone interferes with sound transmission. Next, assess spinal configuration. Place 2 fingers on either side of the spinal column at C7. Run your fingers along the side of the spine from top to bottom. Palpate hard enough to cause blanching. Note any curving or deviation from midline of the blanch lines. Deviation occurs in patients who have scoliosis or kyphoscoliosis. Percussion allows the nurse to gather data about the amount of air, liquid, or solid content in the lungs by listening to sound waves produced by a tapping finger. Press the distal phalanx of the left middle finger firmly on the area to be percussed. Strike this phalanx with the tip of the right second or third middle finger. Avoid striking with the pad of the finger. To percuss correctly, the fingernail must be short. Use a quick, sharp, but relaxed wrist motion. The forearm should not move. Left-handed individuals should reverse these hand positions. Only percuss the interspaces, and in female patients, avoid percussing over breast tissue. Changes in percussion notes are easier to detect in thin patients and more difficult to detect in obese or muscular patients. Resonant tones are heard over the lung tissue. Dull tones should be heard from the 3rd to 5th left intercostal spaces, marking the borders of the heart. Tympany will be heard at the level of the 6th intercostal space over the stomach's gastric air bubble. Dullness will also normally be heard over the 5th to 7th right intercostal spaces, marking the superior border of the liver. Percuss the right and left lateral chest. Resonance should be heard. Hyperresonance may be heard if the chest is hyperinflated or in pneumothorax. Dullness is heard over areas filled with fluid and secretions. Ask the patient to lean forward or sit on the side of the bed. Percuss downward, interspace by interspace. Normally, resonance is heard from the apices to the level of the diaphragm, where resonance changes to dullness. The diaphragm is normally higher on the right due to the anatomical position of the liver. Therefore, dullness is present at a higher point. To assess diaphragmatic excursion, mark the point at which resonance first changes to dullness, usually at the 10th rib. Ask the patient to take a deep breath and hold it. Percuss downward until you again hear a change from resonance to dullness. Mark this point and remind the patient to breathe out. Normally, the distance between the two marks is 1 to 2 inches or 3 to 5 centimeters. Diaphragmatic excursion may be reduced or absent in pleural effusion, diaphragm paralysis, or emphysema. Auscultation provides information about airflow and presence of fluid or secretions in the airways and alveoli. Laminar flow can be described as quiet and unimpeded. Think of it as air flowing slowly and smoothly through a passageway. Laminar flow is present in the peripheral bronchi. Turbulent flow is believed to be present in the trachea and large bronchi. It is noisy and disorderly and causes vibrations which generate sound. When listening to breath sounds, you are hearing sounds generated by turbulent airflow transmitted through the chest wall. Long single-tubing stethoscopes are widely used because they are lightweight, easy to carry, and less expensive. However, although double-tubing stethoscopes are heavier and usually more expensive, they allow the listener to hear sounds more clearly. The tubing length should not exceed 12 to 13 inches. Instruct the patient to breathe slowly and deeply through the mouth. Use the diaphragm of the stethoscope, being sure to warm it. Auscultation should be done anteriorly, laterally, and posteriorly. Listen for at least one inspiratory cycle at each location. Note the duration, quality, and intensity of sounds heard. There are 3 types of normal breath sounds. Bronchial breath sounds are loud, high-pitched, resembling the sound of air blowing through a hollow pipe. They normally are heard over the manubrium and the large airways. The expiratory phase is louder and longer with an inspiratory-expiratory ratio of 2 to 3. As the diagram illustrates, there is a distinct pause or gap between inspiration and expiration. Listen to bronchial breath sounds. Note the pause between inspiration and expiration. Bronchovesicular breath sounds are softer and lower pitched than bronchial breath sounds. They are normally heard anteriorly over the main stem bronchi in the first and second intercostal spaces. Posteriorly, they are heard between the scapulae. As the diagram illustrates, the inspiratory and expiratory phases are equal with a 1-to-1 ratio. Listen to bronchovesicular breath sounds. Note that inspiration and expiration are equal. Vesicular breath sounds are soft and low-pitched, resembling the sound of rustling leaves on a tree. They are normally heard over the peripheral lung fields. The inspiratory phase is longer than the expiratory phase because sounds become progressively more faint and ultimately inaudible as more air leaves the lung. Listen to vesicular breath sounds. Note that inspiration is longer than expiration with a 3-to-1 ratio. When bronchial or bronchovesicular sounds are heard in an abnormal location, such as over the peripheral lung fields, they are termed abnormal breath sounds and indicate conditions which increase lung density, such as consolidation, pneumonia, or a lung tumor. Other examples of abnormal breath sounds are diminished and absent breath sounds. The term adventitious breath sounds is used to refer to sounds not heard in a normal chest examination. They can be classified as either continuous or discontinuous. Stridor, a continuous sound, is caused by an obstruction in the larynx or trachea. It can be described as a loud musical sound of constant pitch and may be heard at a distance from the patient without a stethoscope. Listen to stridor. Stridor is usually heard on inspiration. It may also be heard on expiration. Patients experiencing stridor will be in acute respiratory distress. Causes of stridor include epiglottitis, tracheal or laryngeal obstruction, croup, an aspirated foreign body, or tumor. Listen again to the sound of stridor. The terms used to identify other adventitious sounds are not consistent. Therefore, alternate terms will be given. Wheezes, a continuous sound, are caused by vibration of bronchial walls that are narrowed and constricted. The wall vibrates between a closed and barely open position, producing a musical note. Wheezes can be described as musical tones or squeaks. They may consist of a single note, termed monophonic, or several dissonant notes, termed polyphonic. High-pitched wheezes or sibilant rhonchi are usually heard during expiration and do not clear with coughing. Listen to wheezes. As the airways become increasingly constricted, wheezes may also be heard on inspiration. They are heard in exacerbations of asthma, chronic obstructive pulmonary disease, or bronchial obstruction due to a foreign body or a tumor. Listen again to wheezes.